Hi guys, and welcome to another episode of the Crash Course series as part of the OMFS DCT Survival Guide. Today we're going on to Basic Interpretation of Bloods Part 3, and we're going to be focusing on the bone profile. My name is Jonah Garland, and I'm one of the secondary medical students, and I'm just going into my final year. So let's get started. As always, we're going to go over some aims and objectives. So you want to know what the indications are for ordering a bone profile, be aware of refeeding syndrome and how to minimise the risk of this happening, know the potential complications and signs and symptoms of abnormalities of calcium, phosphate and magnesium. So we'll start off with case 1. You're the on-call DCT and are called to see a patient in A&E. Dorothy is a 71-year-old female and she's a palliative head and neck patient with an SCC on her left tongue. She's been brought in by her husband due to decreased oral intake. Past medical history-wise, she's got palliative head and neck cancer. She suffers from hypertension and COPD. Socially, she has 40 pack years of smoking. She doesn't drink any alcohol. She's clinically frail and mobilises with a stick. So you want to think about what potential problems you could come from this patient. She's had decreased oral intake, so you've got to think about how this might affect the patient and how it might affect her nutritional status. She's likely going to have a pretty low physiological reserve for the background of extensive cancer, and she's been taking minimally orally. This patient's palliative. How far away is this patient from end-of-life care? This is probably a patient you're going to want to inform your seniors about. The consultants tend to want to be informed when their head and neck patients are being admitted or if they have any issues. Things you may want to ask A&E to have done. You want a set of observations so you can tell if the patient's unwell. Do they have any infection on top of the disease? Social history is also really important as well, especially in the elderly and the frail patients. You want to know what their baseline is. Are they able to care for themselves? Do they need help with basic daily activities such as getting changed, cooking, etc.? And this is important for thinking about discharge planning and trying to ensure that you get the patient back to baseline. So we move on. The patient was diagnosed with a T4 SCC 2 months ago and was informed that it was non-operable. She's had progressive deterioration in her speech and her swallow, and now she's only managing a minor oral intake, but she didn't want to come in and cause a fuss. It's important to establish if she's been having any other symptoms. Does she have any signs of infection? The deterioration of the swallow, if it had been more acute, it may suggest an infection on top of the disease, or is it just a part of the progression of the disease? It's important to ask about the patient's weight, has she lost any, and how much has she lost and over what time period. Okay. Can you see some observations from the patient? So she's got an oxygen saturation of 98% on room air, a heart rate of 87, respiratory rate of 15, a blood pressure of 141/91, and a temperature of 36. All in all, these observations are relatively normal. Her blood pressure is a little bit high, but she does have a background of hypertension, so that's probably will explain that blood pressure. There's no signs of infection or any signs of sepsis in her bloods, which is promising. And you'll want to think about what investigations you're going to want to get for the patient. So what bloods do you want to get? FPC, it would be useful to look for inflammatory markers to see if there is any signs of infection. The patient may be anemic, which may be contributing to some symptoms such as tiredness, which could be corrected if it is an issue. Going to want to order some using ease to know what the patient's renal function is. You're likely going to be starting the patient on morphine to help with the pain, and morphine is renally cleared, and it can therefore build up in those who have renal disease. So in these cases, it would be important to give the patient an alternative such as oxycodone. It also tells you about electrolytes, which are important to correct if they're normal, as when severely abnormal, they can cause symptoms or dangerous things such as arrhythmias or comas. You would want to order a CRP to determine if there's any signs of infection. This is likely to be raised due to the inflammatory process of cancer though. And finally, you're probably going to want to order a bone profile. It's important to know what the calcium, phosphate and magnesium are in these patients. It may show signs of bony metastases if there's a raised calcium, and these electrolytes can also be deranged, which is also very important to correct. So you carry out an examination on the patient. So the patient looks cachexic. She has bilateral cervical non-tender lymphadenopathy. There's a large tumour of the tongue extending to the floor of mouth, and there's no signs of clinical infection. So cachexic means there's loss of body and muscle mass, and this is a result of a disease process, normally cancer. The lymphadenopathy is likely a result of the metastatic disease from the cancer, and after the examination you're going to think about what you're going to be doing next. And as previously discussed, this is probably going to be bloods as the next line of investigation. So we get some baseline bloods, got a full blood count at the top. Hemoglobin is a little bit low. We also have a bone profile there, and you can see that the patient's albumin is a little bit low. The CRP is slightly raised as we were expecting. The urea and electrolytes appears to be normal and there's no abnormalities there. The hemoglobin is slightly low due to anemia of chronic disease, and this is secondary to the patient's palliative cancer. The albumin is low, and this suggests that the patient has a low physiological reserve and has had a poor protein intake, which fits in with the history of this patient, and we'll be going on later just to explain a little bit what albumin is as well. So we're going to go into a little bit more detail about what constitutes a bone profile, since that's what we're focusing on today. So you have calcium phosphate, alkaline phosphatase, and a couple more things which we'll go over in a minute. So calcium is obviously one of the components of the bone, as is phosphate. So we'll focus on those two first. So causes of high calcium, things like hyperparathyroidism, malignancy, and renal disease. So just to recap what the parathyroids are and what they do, they're a set of glands which are in the neck and they sit behind the thyroid gland, and they help with calcium homeostasis in the body. So if you have an overactive thyroid, you get too much bone breakdown and you have too much calcium in the blood. The reverse is the same. So if you have an underactive parathyroid, you don't get enough breakdown of calcium, and then you don't get enough in the blood. Malignancy can also cause a high calcium, and examples of this are normally cancers which affect the bone, or cancers which metastasize to bone commonly, so something like prostate or breast cancer. Renal disease also causes both a high and low calcium. Vitamin D deficiency causes a low calcium. This is because you need vitamin D to be able to absorb calcium effectively, so if you don't have enough vitamin D, you can't effectively absorb it. Pancreatitis also classically causes a low calcium, and this is an inflammation of your pancreas, which is an organ in your abdomen. So moving on to the phosphate. So you get high phosphate in renal failure, an underactive parathyroid gland, and rhabdomyolysis. So rhabdomyolysis is where there is a significant muscle ischemia, which leads to the breakdown of muscle, and it leads to the release of the muscle fiber contents, which are harmful to the kidneys, and it can in turn cause kidney damage. In terms of causes of low phosphate, you have alcohol excess, refeeding syndrome, which we'll go over later, burns, and medications. Alkaline phosphatase is an enzyme, a liver enzyme. It is classically high when there is cholestasis. So cholestasis is where there's a blockage in the ductal system, preventing bile getting from the gallbladder and liver and into the gut. And this causes something called cholestasis, which, as I said, classically causes this rise in alkaline phosphatase. Some drugs can cause a rise. Drugs such as allopurinol, which is for gout, erythromycin, an antibiotic, and phenytoin, which is used for an antiepileptic. Bone disease can also cause it high, as can renal disease. Causes of a low alkaline phosphatase is malnutrition and Wilson's disease, which is a genetic disease which can cause a buildup of copper in the body. And the other component part of a bone profile is albumin, and we've added magnesium on because it's commonly ordered with it. So albumin is a carrier protein found in the blood, and it is synthesized by the liver. So high causes of high albumin, things like dehydration, where it's artificially raised because of a lower volume in the blood, or severe diarrhea where you're losing it. Low causes, things like malnutrition, as I've mentioned before, liver disease because you don't have as much synthesis of it, infection, burns where it's lost, and renal disease as well. Magnesium is also an important electrolyte in the blood. Causes of high magnesium are chronic kidney disease, a drug called lithium, which is used for bipolar disorder, or excessive intake of magnesium. Causes of low is low intake, poor absorption, some medications, which we will be going into later, and metabolic diseases as well. So back to the case. After discussion with the seniors, the decision is made to admit the patient for supplementation via a nasogastric tube. At this point, it's probably going to be important to think about including the multidisciplinary team in the management of this patient. It would be appropriate to get dietitians in to review the patient to try and ensure that she's getting optimal nutrition, and also get the patient reviewed by the speech and language therapists, and this is to get them to assess her swallow to see if it's safe or not. A discussion may be had at a later date if it's an unsafe swallow, because the patient's palliative if you're just going to continue swallowing despite the risk, but that's an aside. In these patients, it's really important to get daily bloods to monitor the electrolytes because they can easily become deranged because of the malnutrition. So 2 days after admission, you get a phone call from the nursing staff asking you to review the patient. She's become drowsy. And what do you think could be going on? You want to think about different causes which can cause a change in the mental state. There may be an issue with the patient's blood glucose. However, she doesn't have a history of diabetes, so this is probably relatively unlikely. It may be a progression of her disease if she were to have, say, brain metastases, and she may be suffering from a stroke. She does have an active cancer, which is a risk factor for developing clots. The patient's elderly, so she may have developed an infection, or even something like constipation, because this can precipitate something called delirium in the elderly. So what do you think you're going to do to manage this? You're going to ask the nursing staff to get some observations for you. You're going to examine the patient and get some bloods and try and figure out what's going on. So you get some observations for the patient. She has an oxygen saturation of 97% on room air, a respiratory rate of 15, a heart rate of 77, a blood pressure of 129/87, and a temperature of 37. So for the most part, these observations are normal, and there's no signs of infection. The next steps would be going on to do an A/E assessment. So that's what we do. We do an A/E assessment on the patient. So looking at the airway, the patient's airway is patent and she's mumbling to herself. So that's a good way of telling if someone's airway is open. Looking at breathing, the patient's respiratory rate is 15, oxygen saturations are 97% on room air, the chest is clear and she's got equal expansion. So no issues with breathing. Circulation, the patient's blood pressure is 129/87, her heart rate is 77, and she has normal heart sounds on auscultation. Again, no real issues with circulation. Disability, she does have new confusion. Her pupils ache when reactive to light, and her blood sugar is normal, so that's reassured you about any possible blood sugar causes. Exposure, the patient's abdomen is non-tender and there's no signs of infection. So this assessment, for the most part, is pretty normal, other than the patient being confused. Because the patient's oxygen saturations are okay, we probably want to get a venous blood gas in this case to look for any abnormalities in anything which may be causing the patient's current state. So we get a venous blood gas for the patient, and you can see there are lots of different parameters, and the advantage that you can get results really quickly. A lactate is a marker of anaerobic respiration and is produced when the tissues aren't getting sufficient oxygen, and it's a good marker of when a patient is very unwell, and that is thankfully normal in this patient. As you can see, there are 2 parameters which are abnormal. We've got the hemoglobin, which we've already seen previously in the blood samples, but the potassium is also low. And this would be something which is important to repeat with an actual blood sample which is sent to the lab, and not something that you just put in an analyzer. So you discuss these results with your registrar, who then asks you to get some blood sent off urgently and to contact them once those blood results are back. Okay. So we look at those blood results now. You can see on the left-hand side we've got the bloods which were taken on admission, which we've already seen, and then we've got the bloods which were taken today. So starting off with the full blood count, you can see that the white cells are normal, and you can see that the hemoglobin has stayed sort of static and isn't a concern at this time. We move on to the bone profile. The calcium has stayed statically normal, as has the alkaline phosphatase. We knew about the albumin being low already, and that hasn't really changed, so that's not a concern. But you can see there's been a change in the phosphate and the magnesium. They've both dropped and are now low. Looking at the urea and electrolytes, sodium has stayed static and the renal function is fine, but the potassium has dropped, as was indicated by the venous blood gas. The patient's CRP has stayed static, and there's been no real changes there. Now the patient has presented with some drowsiness, and phosphate can present, when it's low, can give patients an altered mental state such as drowsiness, so that could potentially explain the patient's symptoms. But we need to think about why, when the patient was admitted, her bloods were normal, but they've now dropped the phosphate, the magnesium and the potassium. And this is something called refeeding syndrome. So refeeding syndrome commonly occurs in patients who've had a nutritional deficit for a long period of time. It occurs after they've had a low intake for quite a while and then they start eating again. And it causes a low potassium, a low phosphate and a low magnesium. It's really important to be aware of patients who are at risk of developing refeeding syndrome and be really careful to monitor these patients who are at risk of it. There's a higher risk the longer the patient has been starved, and those with a low BMI as well. So the pathophysiology of the process, the metabolisms of the cells slow down during periods of starvation. And once glucose is reintroduced after they start eating, the cells use up all the magnesium, the phosphate and the potassium very quickly, leading to a deficit. And it can be very dangerous because it can lead to cardiac arrhythmias. And depending how severe it is, some patients may need cardiac monitoring. So complications of a low potassium, it can lead to arrhythmias and muscle weakness. Complications of low phosphate, well, we already know one potential complication, an altered mental status such as drowsiness. It can cause coma, and this also causes muscle weakness as well. And complications of low magnesium, well, low magnesium can lead to a low potassium as well. It can lead to arrhythmias, so dangerous heart murmurs, and can lead to paresthesia, so numbness as well. So in terms of management, you want to have daily monitoring of U's and E's, bone profile and magnesium at patients who are at risk of refeeding syndrome. If they've been starved for a period of time and you're starting to refeed these patients, you always need to check these every single day and replace it with supplementation when you notice them becoming low. It's also important to have a good fluid balance in these patients. It's also important that there is a slow reintroduction of food and gradually build up and try avoid refeeding syndrome from happening. This can be aided by the dietitian's input. And that's the end of case 1. So we're going to be moving on to case number 2 now. So you're the on-call DCT again, and are called by a GP about Serena, an 89-year-old female, and she's known to Max-Ax. She has a palliative SCC of her anterior mandible and is struggling to manage her pain in the community. Medically, she has palliative head and neck cancer. She suffers from hypothyroidism, osteoarthritis, and eczema. Socially, she smokes 5 a day, and she previously was drinking 20 units of alcohol a week, and she currently lives with her daughter. This can be quite a common presentation in head and neck patients. and they're often on quite high doses of morphine. You need to think about what problems can arise in these patients, and she's also palliative, and she may have a poor swallow because of her cancer, so she may also be at risk of developing refeeding syndrome, so that's something to keep in mind with these patients. So we get a bit more of a history from the patient. She was diagnosed with a T4 SCC of her anterior mandible 4 months ago, and she opted not to have surgery and she had chemoradiotherapy instead. The disease unfortunately wasn't responsive to treatment, and she's had a gradual increase in pain and she's now not able to tolerate the pain. She's not really eating or drinking much as a result of the pain, which is understandable. So you get given the patient's observations. She has an oxygen saturation of 99% on room air, a heart rate of 96%, a blood pressure of 133/78, and a respiratory rate of 18, and a temperature of 37.1. These are relatively normal observations. Her heart rate is on the high end of normal, but it is still within the normal parameters. These are relatively reassuring that the patient isn't septic, but infection is always something that you need to keep in mind on. So then we move on to examination. The patient has a fungating tumour through her lower lip. She's got a bilateral non-tender cervical lymphadenopathy. She's got a large tumour extending from the anterior floor of mouth, and it's extending through her lower lip. The lymphadenopathy is likely to be a presentation secondary to her cancer. Cancer typically produces non-tender lymphadenopathy. As you know, patients can develop lymphadenopathy secondary to infection, but this is typically painful, so this is quite a useful differentiator between lymphadenopathy secondary to cancer or infection. It's quite an extensive disease if the tumour is extending through the mandible, lower lip and onto the floor of mouth. Now obviously you want to think about what are your next steps, what investigations do you want to get next, and that's of course going to be get some blood samples. So after the discussion with the seniors, the patient's admitted under MaxVax care to assist with pain control. A referral is also made to the palliative care team to assist with this. It's really important to regularly review these palliative patients and their analgesia, because their need is likely going to go up as the disease progresses, and it's really important to make sure they're comfortable. The palliative care team are useful to get involved as they can help guide what medications to give the patient, and they help adjust dosings. You want to think about what sort of analgesia you're going to be starting the patient on. The patient's likely going to already be on MST, which is a long-acting medication, morphine, with breakthrough doses of Oromorph, which means when the patient develops pain after taking the long-acting medication, they can take doses of Oromorph. The total dose of morphine they've had in a day is used to calculate what dose they should be taking of MST. And these patients can be on really high doses of morphine due to the severe pain they may be getting from the cancer. So you're waiting on the patient's blood results to come back, and later in the day, you've asked to review the patient. She's complaining of some abdominal pain now. What do you think's going on? What causes of abdominal pain can you think that the patient may be having? She could be constipated from all the opioids that she's been taking, and it's really important to think about potential causes of pain. Ask the nursing staff to get some observations while you make your way over to see the patient. So the nursing staff have very helpfully taken some observations for you. The patient's oxygen saturation is 97% on room air. Her heart rate is 102. Her blood pressure is 133/87. Respiratory rate is 17, and temperature is 37.4. Now her heart rate is slightly high, but the rest of the observations are relatively normal. The high heart rate may be pain-induced. She is complaining of pain, and pain is something which drives your heart rate up. But you again always want to be thinking about, does this patient have an infection? How can we manage this patient? So of course, assessing the patient, we're going to do an ATE assessment. Starting with the airway, the patient's airway is patent, and the patient's speaking back to you, so we know that it's fine. Breathing wise, the patient's oxygen saturation is 97% on room air, the respiratory rate is 17, chest expansion is equal, and there's no added sounds. So lungs are fine. Circulation, her blood pressure is 133/87, her heart rate is 102, but it's regular, and there's no added heart signs. So cardiovascularly, fine. Disability-wise, the patient's alert, her blood sugars are 5, pupils are equal and reactive to light, and she has a temperature of 37.4, so that's all normal. And finally, exposure. The patient has generalized abdominal pain, but she doesn't have any guarding. So guarding is when a patient tenses as you're pressing on the abdomen, and this is to avoid pain. It may suggest peritonitis, which is inflammation of the peritoneum, which is a lining within the stomach, and this would indicate a need for a general surgical review urgently, because it can mean, as I said, peritonitis. So you speak to your registrar, who advises you to review the patient's bloods, which are thankfully back now. So this is what you get when you look at the patient's bloods. So we start off by looking at the full blood count. The white cells are normal, high end of normal, but they're still normal. The hemoglobin is 104, a little bit low, but this patient has a chronic disease, so she's likely suffering from anemia of chronic disease. We look at the bone profile. Phosphate is normal, ALP is normal, magnesium is normal, her albumin is a little bit low. Again, this is likely due to the low physiological reserve that the patient has, and the reduced protein intake the patient will have had over the course of the disease progression. The other thing to note is the patient has a high calcium, 3.15. This is called hypercalcemia. What do we think that could be a potential cause of the calcium being so high? We went through some causes earlier. It's likely as a result of the SCC of the patient's mandible. The cancer in the bone can cause hypercalcemia as it breaks down the bone and releases the calcium into the bloodstream. Do we think that the blood results could potentially explain the abdominal pain and the tenderness? It is definitely a cause to think about. So we look at the U&Es, they're all normal, sodium potassium normal, renal function normal, and her CRP is raised, but again this woman has active cancer, so that's not an abnormal finding. So hypercalcemia is defined as a calcium higher than 2.6. Causes include cancer, hyperparathyroidism, medications, and TB. And there's a little mnemonic that we're taught: bones, stones, groans, and psychiatric overtones. And this gives you an idea of what symptoms the patients tend to suffer. So it can result in bone pain from bones, stones, it can result in kidney stones, groans, it can result in abdominal pain, which this patient was suffering from, and it can also result in confusion and depression, and it can also cause cardiac arrhythmias. So this is most likely the result of cancer, and other cancers which can cause this are metastatic deposits in bone, a hematological cancer, and ovarian cancer is an example which can cause one as well. Hypercalcemia is classified into mild, moderate, and severe, mild being from 2.65 to 3, moderate being from 3 to 3.4, and severe being over 3.4. A calcium more than 4 is life-threatening. Management, how are we going to want to manage the patient? So the first line treatment is with IV fluids. You're going to want to give the patient 2 to 4 litres of sodium chloride 0.9% over 24 hours, so lots and lots of fluids. They may also need IV bisphosphonates. The bisphosphonate of choice is normally zoledronic acid. However, this does need to be avoided in patients who have a creatinine more than 400. It takes around 5 days to work, so you need to be careful not to give further doses until after this, because it might result in hypocalcemia. Another thing you may want to do is carry out a medication review. So you want to review the medications which may affect renal blood flow, such as ACE inhibitors, example of which is ramipril, angiotensin receptor blockers such as losartan, and NSAIDs such as ibuprofen. or any medications which can worsen hypercalcemia. So these are medications like lithium, thiazide diuretics, and calcium supplementation. Hopefully, giving all these measures, normal calcium levels should be achieved in around 3 to 7 days. So moving on to our last case, case number 3. You are again the on-call DCT and are called to see Charlie, a 52-year-old male who has a fractured mandible. He has a past medical history of alcohol excess, type 2 diabetes, and hypertension. He smokes 15 a day, drinks more than 80 units a week, and is unemployed and currently lives alone. It's always really important to be aware of patients' medical histories. Alcoholism can cause medical issues with patients, and it's important to know what pathways to put these patients on when they're admitted. And you can always find this information on your trust guidelines, and it's always the best place to get the correct information for the particular place that you're working in. So we get the history from the patient. The patient was allegedly assaulted with multiple punches to the face. There is no loss of consciousness or amnesia of events. There's no vomiting. There's paresthesia to the lower left lip. The patient is complaining of pain and a deranged occlusion, and they've been cleared from head injury and C-spine injury by A&E, hopefully. The assault happened 3 days ago. So this is a delayed presentation of a fractured mandible, and it may mean a potential infection of the fracture, so therefore it's really important to make sure this patient gets started on some IV antibiotics quite promptly. As always, we get some observations for the patient. The oxygen saturations are 96% on room air, which is fine. The patient's heart rate is 103, thus slightly tachycardic. The patient's blood pressure is 129/89. The respiratory rate is 17, and the temperature is 37.2. So the heart rate, that may be pain-induced, but your heart rate goes up when you drink alcohol. So that could be driven, if the patient has been drinking on that day, by the alcohol. So you move on to your examination. There's some swelling to the right mandible, and there's a palpable step on the left parasymphysis and right angle of the mandible. When you try and move the mandible around, there's a mobile segment, and the patient is telling you that they have paresthesia to the lower left lip. You can see a step and a tear in the mucosa intraorally around the lower left 3 and 4, and the patient definitely has a deranged occlusion. Now, the reason it's really important to carry out a thorough examination of these patients preoperatively, and noting things like the numbness, is it can be really important medico-legally. You want to know, is it the injury that caused the damage, and things like that. So this patient has a 3-day-old fractured mandible. You're going to want to get this patient admitted and started on IV antibiotics. You inform your seniors, and the patient's prepped for theatre the next day. You want to make sure that you've got all the appropriate investigations carried out before this patient has a GA. It's important to have all the basic blood tests, and given the patient's medical history, he's diabetic, you'll want to have an idea of how well controlled his diabetes is. It can impair the healing of bone. The patient's also a smoker, another thing which impairs healing of the bone. This patient is also an alcoholic, so it's really important to check his liver function, because this may be affected because of the excess alcohol intake, and that may impact things like clotting and the production of albumin, as I mentioned earlier. Alcoholics tend to have a poor oral intake as well, so we might be deficient of electrolytes. So again, be aware of this and any potential complications this may come with it. As this patient's an alcoholic, it's important to start the patient on an appropriate withdrawal pathway. This will be unique to your trust, but normally it involves with starting them on something like Pabernex, which is B vitamins, and giving them chlordiazepoxide or lorazepam, and this is to help them to stop withdrawal from alcohol. So you're assured by A&E that the patient's clotting and liver function tests are normal, which is very reassuring. So you have a look at the bloods, and you can see the full blood count. The patient has a high white cell count and neutrophil count. in keeping with infection or inflammatory process. This patient did have a fracture 3 days ago and may be infected. The patient has a low hemoglobin and a high MCV, main cell volume. So this is a macrocytic anemia, and that's quite a common presentation in alcoholic patients. Looking at the patient's urea and electrolytes, renal function is fine, the sodium is fine. The patient does have a low potassium. Patient also has a CRP of 55, which you would expect if a patient has had a fractured mandible. So you discuss this potassium result with your senior, and they advise you to start the patient on oral supplements, which would be Sandoke. So the case continues. The patient's taken to theatre the next day and is recovering well. However, there's been no improvement in the potassium levels despite being on the supplements which they've been started on. So you speak with your senior and they ask you to get a bone profile because a low magnesium can sometimes cause a low potassium. So that's exactly what you do. You get a bone profile and you have a little look at that. So you get your bone profile and you have a little look at it. You can see there's two abnormalities. First being the patient has a low albumin at 31. And there could be two different reasons for this. The patient likely has a poor diet, very typical of alcoholic patients. They don't eat a particularly well-balanced diet. So they may have a low protein intake and therefore cause a low albumin. It also may be due to the failure of the liver being able to produce the proteins as a result of the alcoholism leading to liver disease. It may also be multifactorial. You also note that the magnesium is low. So this is hypomagnesemia, which we're just going to go over. So hypomagnesemia causes include a low dietary intake, poor absorption, some medications, and metabolic abnormalities. Symptoms include weakness, muscle cramps, arrhythmias, seizures, and low potassium. And as we've just seen, it can be a cause for low potassium. A low magnesium in alcoholics is multifactorial. Alcohol acts as a diuretic for magnesium and causes losses through urine. And there's also likely a dietary intake element to it, and they may have losses through diarrhea as well. Medication causes are things such as loop diuretics such as furosemide, antibiotics like gentamicin, high dose PPI, so omeprazole, and other medications such as cyclosporin, which is used for immunosuppressants. It can also cause a low potassium because the potassium efflux channel is inhibited by magnesium. So if you don't have magnesium, this channel isn't inhibited, and therefore you have too much excretion of the potassium. Moving on to the management. The mainstay of management is oral replacement. However, if the patient does have a severe deficiency, the patient may need IV replacement. And if they have IV replacement, they will need cardiac monitoring, and therefore the patient will likely need to go to HDU for this. And that is the end of case number 3. And we do have some further reading materials as always. There's the On-Call in Maxillofacial Surgery, which is a great book and really is your bread and butter for working in MaxVax. BNF will give you great information on medications and side effects, as does Oski Stop, Geeky Medics, Mind the Bleep give you really good information about these medical conditions which can happen. And thank you guys so much for joining us. If you have any questions, please do email. And yeah, get onto the website, have a look at our other resources and our other videos, and we'll hopefully see you at another one of them. Thank you guys.